Before I start discussing the pathological aspects of Alzheimer's disease, I would like to start the discussion with a story. The story began in 1906, more than 100 years ago. Dr. Alzheimer, one of the patients of Dr. Alzheimer, Augusta D, died. She was a lady of around 50 years and she was having a chronic forgetfulness, aggressive nature, and this kind of problems. Her husband brought her to the Frankfurt psychiatric hospital, and she died in 1906. And Dr. Alzheimer was very much curious about this case, and he performed an autopsy. And in the autopsy, he found a lot of interesting, peculiar findings actually in the cerebral cortex of that lady. A lot of plaques and tangles, and he then published about this case, which later known as Alzheimer's disease. And the fascinating aspect of Alzheimer's disease is this, that even after more than 100 years, whatever Dr. Alzheimer had found in 1906 and that period of time before he died, that still stood the test of time. Now, coming to Alzheimer's disease is particularly the most common cause of dementia in the elderly persons, and when you think about dementia, there are many causes of dementia. Let me start with what is dementia. Dementia is not just memory loss. Dementia has a classic definition. It means acquired progressive deterioration of your cognitive skills or cognitive abilities, which impairs your day-to-day activities. And cognitive skill does not just mean your memory, it means your reasoning skill, your thinking ability, your arithmetic skill, your mathematical skill, all these kind of things, your visuospatial abilities, all these things together. So usually Alzheimer's disease patients, all these things get affected. Now they start with episodic forgetfulness actually. Now coming to Alzheimer's disease has a lot of risk factors. Obviously, one of the most important risk factors is the aging. As you age, there is more chance of having Alzheimer's disease. If there is a history of trauma in brain, that also increases the risk. Even they have found that female gender is also increased risk. A particular aspect which is very, very important is genetics of Alzheimer's disease. And there are four notable genes which are associated with the development of Alzheimer's disease. The most important one, which is associated with majority of cases of Alzheimer's disease, is apolipoprotein E, which is located on chromosome 19. Mostly people has confusion that this most important gene is APP, amyloid precursor protein, on chromosome 21. That is not correct. APP is basically involved in less than 1% cases, and this one could, at least they are associated with 40 or more than 40% cases. And now there are two other genes also that's called presenilin 1 and presenilin 2. These genes are also involved in the pathogenesis of this. Now basically Alzheimer's disease you can divide into two groups. One group is called early onset, another is called late onset. Early onset typically arises between 30 to 60s, and late onset, typical onset in the 60 after 65 they say. And majority of the cases of Alzheimer's disease which you see are late onset. That means you see usually after 60s. And the most important risk factor, genetic risk factor, which is associated with late onset is apolipoprotein E. Particularly there's epsilon 4 allele is there that is associated with this. Now you come to the pathology part. What do you expect morphological? What are the morphological changes do you expect in Alzheimer's disease? Alzheimer's disease, basically the pathology, they start with atrophy in the medial temporal lobe, particularly the entorhinal cortex and the hippocampus. And hippocampal atrophy could also be seen. And if you look at biopsy, which is the best way to actually to diagnose this, you see certain features. One important feature is the presence of amyloid plaque, beta amyloid plaques, which usually call neuritic plaques or senile plaques. So basically there is a amyloid precursor protein is there, which is present in all individuals. But if this amyloid precursor protein, if it is cut into an abnormal short fragment, which usually carries 39 to 42 amino acid, this fragment is the problematic one. And when we get this kind of fragments, small fragments from the APP, which carries 39 to 42 amino acids, they get aggregated with each other in the brain. They cause this amyloid plaque formation, and the surrounding area there is a lot of dystrophic neurites seen. You can think in this way that you can think the brain like a children park which is full of greenery, and somebody mischievously dump a lot of garbages there in some places of that park. So what happens, the surrounding neurons, due to the toxic effect, they starts to die. The surrounding grasses, the greenery, they start to disappear wherever those dumps have been dumped in that children park. So basically amyloid plaques are focal aggregation of dystrophic neurites surrounding the deposition of those toxic abnormal beta amyloids. Second thing usually we see, that is NFT, called neurofibrillary tangles. A neurofibrillary tangle, the idea is this, that all our neurons, their actions are usually made with a lot of microtubule associated proteins, microtubule filaments actually. And a key microtubule associated proteins is usually tau protein, tau protein. And this tau protein gets abnormally hyperphosphorylated in this condition. So when this tau protein gets abnormally hyperphosphorylated in the case of Alzheimer's disease, it becomes not only toxic, but also it cannot hold all the microtubules together in the action part of the neuron. You can think in this way that you can think the actions are like aggregate of a lot of straws, the straws which we use for drinking soft drinks. So if those straws are actually held together by a protein called tau protein, if the tau protein becomes abnormal, hyperphosphorylated, the component of the axons, they start to disintegrate from each other, and that leads to the degeneration of the neuron, and the neurons start to die. And one important aspect of this is that senile plaque or neuritic plaques are actually extracellular, because amyloid is always get deposited extracellularly. Compared to that, the neurofibrillary tangles are usually seen in intracellularly. But after the death of the neuron, you can see the neurofibrillary tangles, which usually look at tadpole shaped outside of the cell. And typically uses a silver stain called Bielschowski stain to identify the neuritic plaques and the neurofibrillary tangles. But if you want to detect the amyloid, the best stain is obviously the Congo red, which you can see the apple green birefringence in polarizing microscopy. So these are the two key findings actually. The two findings are amyloid plaques, and one is senile plaques, or another is neurofibrillary tangle. And these two things are also seen in normal people, but they are seen in more in number in patients of the Alzheimer's disease. This is the key concept. The third thing you can see is cerebral amyloid angiopathy. The amyloid could be deposited in the blood vessel wall, also in patients of Alzheimer's disease. Another key aspect that I would like to mention, that usually Down syndrome patient, trisomy 21 patients, they are at more risk to develop Alzheimer if they survive beyond 40 at very early age. They usually develop Alzheimer at a quite early age. The reason is they say that it's a gene dosage effect. Normal people has only 2 chromosome 21, and chromosome 21 is the location for the amyloid precursor protein. So if you have 3 chromosome 21, which is seen in the Down syndrome, you are more at risk of developing Alzheimer's disease at early age. It's like if 2 factories are producing some amyloid proteins and they take 60 years or 65 years, if you replace it with 3 factories, more number of factories, they would manufacture that protein in less span of time actually. They would do it in 40 years. That is the basic idea. And another very important aspect of Alzheimer's disease is neurotransmitter, the role of neurotransmitter acetylcholine. If Parkinson's disease is a problem of the neurotransmitter dopamine, there's a decrease in the neurotransmitter dopamine. Alzheimer's disease is basically decrease of acetylcholine is seen. And that's why we use cholinergic inhibitors in this condition. And particularly there's a nucleus basalis of Maynard, a particular area in the brain, which has a lot of cholinergic neurons, and the cholinergic neurons in that part of the brain usually gets lost in cases of Alzheimer disease. So Alzheimer disease, in a nutshell, I would like to say that this is a most common cause of dementia in elderly population. And dementia, I told you, it's a acquired progressive deterioration of your cognitive skill, which impairs of your day-to-day activity. That would be that must affect your day-to-day activity. That's a key part, and there are many causes of dementia. Actually, it could be vascular cause of dementia, it could be frontotemporal dementia, it could be Parkinsonism associated dementia, Lewy body associated dementia, it could be some reversible cause of dementia like associated with vitamin deficiency, vitamin B12, vitamin B1, niacin, all these kind of things. But the most common in the elderly population which you see is Alzheimer disease. And Alzheimer disease, as I mentioned, typically the problem starts in the medial temporal lobe, and microscopically what we see three key things. One is neuritic plaques or senile plaques, second we see neurofibrillary tangles, and third we can see cerebral amyloid angiopathy. Another thing I forgot to mention, actually, you can also see a kind of hydrocephalus ex vacuum in this condition. That is the point.